Welcome to Chapter 45, Part 2, Head Injuries and Nervous System Tumors. We're going to start off with head injuries. There's three major causes of brain damage in childhood. It's usually falls, motor vehicle injuries, or bicycle or sports-related injuries. Force of intracranial contents cannot be absorbed by the skull, and musculo-ligamentous support of the head. The head is especially vulnerable to acceleration-deceleration injuries. A child's response is different than that of an adult because of larger head size in relation to the body and because of insufficient musculoskeletal support. Primary head injuries. These are injuries that occur at a time of physical trauma. It could be skull fractures, contusions, intracranial hematoma, diffuse injury. Subsequent complications such as hypoxic brain damage, increased ICP, infection, and cerebral edema can occur. Look at box 45-3 on page 1430 of your textbook for clinical manifestations of acute head injuries. Okay, now let's talk about concussion and contusion. Concussion is an alteration in neurologic or cognitive function with or without loss of consciousness. Transient and reversible, results from trauma to the head, generally followed by amnesia and confusion. Contusion is visible bruising. Laceration is tearing of tissue. We have the coup, which is bruising at point of impact, and then we have the contracoup, which is bruising at a site far removed from the point of impact. Possibility of multiple sites of injury. Because of flexibility, the immature skull can withstand a greater increase in deformities before fracture. To produce skull fracture in infants, force must be extreme. Types of skull fractures can be linear, depressed, comminuted, basilar, open, and growing. Look at figure 45-5 on page 1429 for mechanical distortion of the cranium during a closed head injury. Let's talk about complications of head injuries. We have the epidural hemorrhage. This is bleeding between the skull and the dura. We have subdural hemorrhage, bleeding between the dura and the arachnoid membrane. We have cerebral edema that's associated with traumatic brain injury. We have increased intracranial pressure with herniation. And then we have post-traumatic syndromes. These are such as post-concussion syndrome. It's common sequel to head injury with or without loss of consciousness. Symptoms can develop within hours to days after a mild head injury, but can also occur after moderate to severe head injury. Manifestations vary with the child's age. Post-traumatic seizures, these are more common in children than in adults, occur in a number of children who survive a head injury. They're more likely to occur in the first few days after a severe head injury. Then we have structural complications such as hydrocephalus, and then we have duration of manifestations that can last from several days to months. So diagnostically, we're going to get a detailed history including past and present health information. It's an important aspect of care as certain allergies and disease processes may produce similar symptoms. Assessment of airway, breathing, circulation should be the initial assessment. And then you want to assess for signs of shock. Neurologic examinations such as level of consciousness assessment should be performed minimally every 4 hours. And you want to wake the child at least twice during the night to assess level of consciousness. Assessment of vital signs should be done frequently. You can have special tests such as a CT scan, an MRI, and behavioral assessment can help to provide a more definitive diagnosis. You want to look at your nursing alerts on page 1431 of your textbook, and then you also want to look at see the box on emergency on page 1431 too. Care management. Care occurs in the hospital setting if the child has severe injuries, lost consciousness for several minutes, or for prolonged or continued seizures. Nothing is administered orally at first. For surgical therapy, for scalp lacerations, may require suturing. Depressed fractures require surgery to reduce and remove bone fragments, and then of course the torn dura mater is sutured. Prognosis, it depends on the extent of the injury and occurrence of complications. A true coma usually doesn't last more than 2 weeks. Eventual outcome can range from complete recovery to persistent vegetative state or brain death. You want to assess frequently vital signs, neurologic status, and level of consciousness. Provide analgesia and sedation. Perform careful observation and recording. Provide family support. Look at the family-centered care. Maintaining contact in the box on page 1432. Arrange for rehabilitation. Teach parents about prevention of injury and complications. Look at your nursing alerts on pages 1432 to 1433, and then your medication alert on page 1433. Let's talk about submersion injury. Submersion for more than 10 minutes with failure to regain consciousness at the scene or within 24 hours is an ominous sign and indicates severe neurologic deficits in the child. A major cause of accidental death in children is most common from submersion injury. It can occur with even small quantity of water, even as small as a pail of water. Near drowning, survival for at least 24 hours after submersion would be key importance. Pathophysiology. They can have hypoxia, primary cause of injury within minutes. Hypoxia leads to a coma and ultimately cardiac arrest. Pulmonary edema results from the absorption of fluids that are aspirated. Atelectasis occurs as a result of the aspiration of fluids in non-ventilated alveoli. Airway spasm may occur as a result of aspiration as well. Aspiration. There's no clinical difference seen when a child aspirates fresh water versus salt water. Hypothermia. Children are at an increased risk because of the largeness of surface area in comparison with body mass. Hypothermia is common after submersion. Submersion is cold water that can decrease the body's oxygen demands temporarily, which can potentially result in a better outcome than if the submersion occurs in warm waters. However, prolonged submersion can ultimately lead to cardiac arrest. So look at emergency resuscitative efforts take place at the scene. Management's based on the degree of cerebral insult. Aspiration pneumonia, frequent complication that occurs about 48 to 72 hours after the episode. Hospitalization for observation is necessary. Almost half of asymptomatic or minimally symptomatic children develop complications during the first 24 hours after the incident. Prognosis, it's the best predictor is the length of the submersion. Nursing care. Care depends on the condition of the child. Help the parents cope with feelings of guilt. Parental anxiety is related to prognosis, and teach prevention of submersion injuries. Let's talk about brain tumors and neuroblastoma. They're derived from neural tissues. CNS tumors account for approximately 20% of childhood cancers. CNS tumors are difficult to treat and survival rates are poor. Brain tumors are the most common solid tumors in children. They can arise from any cell in the brain or spinal cord. Infratentorial tumors involve the cerebellum and the brainstem. Supratentorial tumors occur mainly in the cerebrum. Signs and symptoms are going to be related to anatomic location, size, and child's age, and can include seizures, headache, memory loss, decline in school performance, vision loss, increased ICP, personality changes, behavioral changes, irritability, loss of developmental milestones, precocious puberty, growth failure, ataxia, dysmetria, nystagmus. Look at page 1436 for symptoms based on tumor location and child's age. Diagnosis is based subjectively on presenting clinical signs, objectively with neurologic exams, and confirmed with surgical biopsy. Most common diagnostic procedure prior to surgery is an MRI. Other diagnostic tests include lumbar puncture, CT scan, EEG. Definitive diagnosis based upon specimens obtained during surgery. Let's look at care and management. It depends on the type of tumor. We have surgery. That's the optimal treatment. It's a complete surgical resection of the tumor. We have radiotherapy. It's avoided in children less than 3. They may be used to shrink the tumor prior to surgery in older children. There is chemotherapy. can be used as a primary treatment or used to delay radiation until the child is older. Chemotherapy may be a challenge because of the blood-brain barrier. There is combination of modalities depending on the tumor's location and the child's condition. One or more treatment options may be combined in an effort to improve the outcome. Prognosis is variable and depends on the type and location of the tumor, the size of the tumor, and the extent of the disease, and whether or not the tumor may be resected safely. The current overall survival rate for children under 15 is about 75%. Nursing care, we want to prepare the child and family for diagnostic and operative procedures, consider how the disease affects the child's body image. Baseline assessment data, including vital signs physical assessment, should be obtained upon admission. Report any sudden changes in condition. Note any changes in vital signs. Assess and note the location, severity, and duration of headaches. Observe gait at least once a day. Prevent post-operative complications. Take vital signs frequently until the child is stable. Perform frequent neurological exams. Look at page 1437 to be sure to read all of the nursing alerts. Support child and the family, and then promote return to optimum functioning. Neuroblastoma is the most common malignant extracranial solid tumor of a childhood. Majority of tumors develop in the adrenal gland or retroperitoneal sympathetic chain. Other sites include the head, the neck, the chest, and the pelvis, commonly referred to as the silent tumor, because children may display few symptoms and metastasis may have already occurred before diagnosis is made. Diagnosis. The objective is to locate the primary site and sites of metastasis. Signs and symptoms depend on the location and stage of the disease. Skeletal survey of the skull, neck, chest, abdomen, and bones could be possible or potential. And then we have the radiologic studies and bone marrow evaluation. And then, of course, the intravenous pyelography to evaluate renal involvement. Treatment. Clinical staging is done to establish treatment plan. That's the most important thing to do. Surgery to remove tumor and obtain biopsy samples. Radiation may be used for emergency management of a massive neuroblastoma, but is otherwise complicated in intraspinal tumors because it can cause vertebral damage. Chemotherapy is a cornerstone therapy for extensive local or disseminated disease. Stem cell rescue may be used to obtain a longer remission rate. Prognosis, 95% survival at 5 years for low-risk disease, 30% survival at 5 years for high-risk disease. In general, the younger the patient is at diagnosis, the better the prognosis. Tumor may regress spontaneously as embryonic cells mature and with development of active immune system. This concludes Part 2 of Chapter 45.